everyone. I'm Kelly Garber. I'm the co-chair of the Health Policy Committee, and I'll welcome you to this evening's Children's Health Policy Learning Collaborative. I'm really excited because I get to introduce a friend and colleague from the Medical University of South Carolina, Miss Meg Wallace. She is a wealth of knowledge. I'm going to actually read her bio for you so I don't miss any of the amazing things that she's done and continues to do every day. So Ms. Wallace is a licensed independent social worker for the state of South Carolina. She's a clinical instructor and the associate director for clinical operations for the National Crime Victims Research and Treatment Center within the Department of Psychiatry and Behavioral Health Sciences at the Medical University of South Carolina, and the lead coordinator for the Telehealth Outreach Program within the Mental Health Disparities and Diversity Program. Ms. Wallace also serves as the director for the MSW Field Placement Program at the National Crime Victims Center. She completed her undergraduate coursework at the College of Charleston, graduated with a Bachelor of Science in Psychology. Ms. Wallace earned her master's in social work from the College of Social Work at the University of South Carolina. She completed her generalist practice internship at the National Crime Victims Center and her advanced practice internship at the D. Norton Child Advocacy Center. Ms. Wallace is trained in evidence-based treatment of trauma-related mental health issues, specifically focusing on child abuse and loss by homicide. For the last 8 years, Ms. Wallace has served as the coordinator for a federally funded Victims of Crime Act service grant aimed to improve resources for survivors of homicide and victims of crime with barriers to traditional office-based treatment. In addition, for the last 5 years, Ms. Wallace has served as the lead coordinator and program therapist, providing trauma-focused cognitive behavioral therapy to children and adolescents across the state through the Telehealth Outreach Program. Ms. Wallace has expertise in traumatic loss, evidence-based trauma treatment, telehealth service delivery, and community-based mental health approaches. Ms. Wallace is the MUSC Medical University of South Carolina liaison for the South Carolina State Suicide Prevention Coalition and an active committee member of the American Foundation for Suicide Prevention, Charleston area out of the Darkness Walk. So please welcome Meg Wallace.
Thank you, Kelly. That makes me sound much more impressive than I probably am, but I appreciate it. So I'm going to try and share my screen because I have just a few slides to share with you guys. I'm going to see if I can get it to pull up real quick. And is everyone able to see the slides?
Yes.
Perfect. So as Kelly mentioned, I'm kind of here representing the Telehealth Outreach Program at MUSC. And really what our services are is trying to bridge the gap for underserved populations in South Carolina. And our program specifically focuses on working with kids. But I wanted to talk a little bit about telehealth in general, telehealth policy, and then talk a little bit about our program. So the great news is there's a robust amount of literature on the efficacy of telemental health services. So it's been shown to be very effective in treating adults across many populations and disorders. There's less research on the child side, but that's definitely starting to change. We're starting to see a lot more programs, even prior to the pandemic, of people starting to do non-inferiority trials and really demonstrate the utility of telehealth services in behavioral health. And so another really cool part about working at MUSC is that MUSC has really been an innovator in telehealth services, particularly in the trauma field. As far as adult services, a lot of MUSC staff and personnel or trainees that were trained at MUSC have been a part of some of the big RCTs related to prolonged exposure, some non-inferiority trials, and lots of pilot studies for like evidence-based trauma-focused treatment for adults. And then something that's really exciting that I get to be a part of is the program that I currently work in, as well as my other position at the Crime Victims Center. We have been a part of some of the first pilot studies coming out across the country on using telehealth to deliver trauma-focused CBT for kids. And the great news is that it's getting lots of public awareness and really with the goal of getting the word out there that telehealth should be here to stay, and that it really can be used to address a lot of health disparities across the country. So as far as kind of recently, specifically related to the pandemic, telehealth is kind of an unusual process depending on the state that you currently reside in. So prior to the pandemic, pretty much every state had different rules and regulations on how they handled telehealth services, specifically related to mental health, that's not provided by a physician. So psychologists, social workers, counselors. And then the pandemic hit, and our country kind of immediately and rapidly changed to having all of our services provided via telehealth. And the way that it kind of quickly opened up, and there were a lot of federal guidelines coming out and a lot of changes across the states. And so some of the things that we're seeing that are currently the way that we're functioning and really hoping kind of stay the course post some of the pandemic is some of the policies that came out to encourage access during this time. And so some of the things that have happened is expansion of HIPAA approved platforms. So prior to the pandemic this year, there were really strict regulations on platforms. There has definitely been expansion of use, and there's some pros and cons to that. You know, there's some good aspects of having it limited to certain platforms for reasons like HIPAA, confidentiality, things like that. But what we have also found is that sometimes if you're not in a large agency, so I come from a huge institution that has lots of resources, an IT department, so we have access to lots of approved platforms prior to this, but smaller agencies or smaller practices had a lot of trouble getting these licenses because they're often very, very expensive. And so what has happened is that some of the newer policies coming out have expanded it to things that still have end-to-end encryption or direct calling features, which helps with security, but have a lot cheaper user licenses to, I think, allow smaller agencies or huge hospital systems to be able to access and utilize these services. Another thing that happened is Medicare already had a pretty robust telehealth policy, but they expanded their coverage when the pandemic happened. And essentially, two of the biggest things that came out of that was allowing providers to provide services directly to patients' homes instead of to centers, and then expanding outside of rural locations. So prior to the pandemic, it was really focused on addressing just rural health disparities. And obviously, as we've experienced, not just rural people have been affected by the pandemic. And I think what the hope is the recognition that this certainly can address the health disparities in very rural areas, but there's also a lot of urban underserved areas as well that telehealth can help to benefit. Medicaid is another thing that recently, during the pandemic, coverage has expanded. This is a little bit harder because it is state controlled. So many states prior to the pandemic actually did not reimburse for psychologists, master's level social workers, or other master's level clinicians, which made it really hard to provide telemental health services. So South Carolina is a great example that prior to the pandemic, none of our psychologists or social workers could bill for telehealth services. So we were doing them, but it had to be funded by grants or other mechanisms. Only our MDs were able to get reimbursed. And at least in our institution and many of our state agencies, the people actually providing therapy are not the medical doctors. They're managing prescription medication needs, but they're not actually doing weekly services. And so since the pandemic hit, one of the things that has happened is a lot of states have opened that up and allowed psychologists or social workers to start billing and reimbursing for telehealth. Which again, I think has a lot of potential good outcomes for the future of whether or not these services can really be sustained and continue to help provide access to really needed services across the country. And one of the difficulties with that is that it is state dependent, but I think more and more states have opened up and seen the utility given the current situation, but are able to apply it to other reasons why telehealth would be helpful. So we're really hopeful that coverage expansion continues to happen. Another thing that happened was licensure requirements. And this is something that I think applies to many disciplines. For instance, practicing across state lines, any type of professional role, you have a license within a state, you're able to practice within that state, but it doesn't necessarily mean you can practice in another state. And so there are certain mechanisms already in place, like SIPACT, which is certain states have agreements to allow psychologists to practice across state lines with partner states. And that has since expanded for a few different states. It's, again, state dependent, but really looking at, for very underserved states across the US, and you have, neighboring states that have experts or professionals that could provide those services, in the future direction, is there a way to expand licensure or temporary licensure to be able to provide those services for patients that can't get them or otherwise would have to drive to a different state to access those services? As far as for providers and people working in the field right now, it's still important to check state to state. Every state is different. So for me, I live in South Carolina. There are some parts of my job where Georgia's like, yep, right now we'll reimburse for it, but North Carolina won't. And they're right on the other side of us. And so you definitely have to right now check, because it's not across the board the same. Other additional considerations, though, to think about when you're providing telehealth or when you're referring to agencies providing it, is currently during the pandemic, a lot of things have opened up and are allowing some level of interstate services, but that doesn't include things like malpractice coverage across state lines or coverage from insurance carriers. So those kind of three things meld together. So a great example is where I'm at is our university has, essentially given us the go ahead for medically necessary services. So if I'm in the middle of treatment with a patient and they have some sort of mental health crisis or safety concern, they've essentially, and they're out of state, they've gone to a different state for some reason, and we have telehealth services to access it. They've said, go ahead and see the patient. It's fine. We'll figure it out. But they don't want us doing that long term, because ultimately our malpractice may not cover in the same way that it does for in-state services. Their insurance may not pay for that visit. And so that's something that to keep in mind in terms of services that are being provided. And that varies across many different states across the US. And unfortunately, I think because telehealth it's not new, it's been around for years, but it's kind of the buzzword right now, especially right now. These policies are ever shifting and changing. And so one of the things that I wanted to share with you guys that I'm not sure if you're aware of is that telehealth resource centers exist across the US. And so one of the really cool benefits of these is that they have regional resource centers that are dedicated to providing resources, tip sheets, consultation, policy guides, how-to guides related to telehealth that have specific areas across the US that they help support. And so, there's a Southeastern resource center. And so that's something that you would be able to access depending on the area and the country that you're living in. And it's not just tied to behavioral health. So these are actually more broad in terms of medical telehealth, behavioral telehealth, and can really be a great resource to start. They also often have contacts for kind of state dependent resources. So in my state of South Carolina, we have the South Carolina Telehealth Alliance, which is a huge organization that really helps do a lot with telehealth in our state. They also help to provide some funding for equipment and getting programs started up to do telehealth. And so if, I know about that because of where I work, but if I didn't, I could go onto the Telehealth Resource Center for my region. It would then lead me to some additional resources within my state. So if this is something that your agency or your organization is really looking into, even post pandemic, to expand telehealth services, I'd strongly encourage reaching out to contacts within these centers to get tips and not reinvent the wheel. So really to learn from the people who are already doing this and can help further things faster instead of having to start from scratch. And so briefly, just to tell you a little bit about what our program looks like, when we started this program about five years ago, which is actually when I met, I believe Kelly was that year. One of the things that the grant that we had that helped to fund and start this program was looking at health professional shortage areas. And so this is just a HRSA map of the United States with some data from 2019. And I think just gives some really great perspective of what the United States looks like in terms of professional shortage areas. So it was actually, we look at South Carolina, for example, there's 3 parts of the state where it's not considered a shortage area, which is Charleston, Columbia, and Greenville, but the vast majority of our state is considered a shortage area. But if you expand out to the whole US, a large percentage of our country is considered a health professional shortage area. And so this is really where telehealth has utility, is looking at some of these states where the entire state is dark blue. Telehealth could be a great access. I just did a presentation with some of our partners from the Dakotas who've said that telehealth has actually saved lives and so much money for their state, because otherwise people are on the road for 2.5 hours to get to the nearest doctor. Or get to the nearest child advocacy center. And so there really is utility in this. And so our program is the top program, which is Telehealth Outreach Program. And really what we are doing is providing school-based and home-based mental health services for children who've been exposed to trauma or maltreatment. So we are a very specialized program that's doing very specific work related to the trauma field. And ultimately our goal is to reach those underserved populations. So the kids that can't drive in, that we're never going to get seen for health services, we're trying to reach those kids so that they actually can access mental health treatment. And what we provide is the gold standard for trauma treatment, which is TFCBT. And it allows us to get that service that's really hard to find in rural areas or underserved areas, get that out there via telehealth. So the model's already there. It's just the way that we're delivering it that's different. And so I'm not going to belabor a lot of this, but what's been really cool is that we recently just published a pilot study of our program with over 70 children. And one of the things that I thought was really neat is that we had almost 90% of our population was racial and ethnic minorities. One of the things that's been really cool is we also have multiple bilingual clinicians. And so over 30% of our cases, we actually did treatment in Spanish. And so in our state, at least, some of the more rural areas don't have access to bilingual clinicians, so they'd be using a phone interpreter. And by being able to telehealth across the state to see these patients, we were able to provide monolingual Spanish-speaking patients with a Spanish-speaking provider located at MUSC 4 hours away and still be able to do treatment over the computer. And then we have a little bit of a split between school-based and home-based, partially because our program sees kids year-round. So we're a school-based program, but we continue to see kids in the summertime so that, again, leaving school isn't an access barrier. And with this study, one of the things that I think was also really neat is that almost 90% of kids completed treatment with us. So essentially, almost 9 out of 10 children completed the treatment. About 80% of the caregivers participated in treatment, which is really hard to get caregivers to join for weekly mental health services because they usually have jobs or other things that keep them from coming in. And because of telehealth, we were able to do that. And there's just really high satisfaction. And what we found is that the effects are similar to in-person. So we didn't really see a difference between doing in-person treatment versus telehealth. So it basically shows that the treatment doesn't change. It's just the mechanism of getting it there. And in fact, in normal in-person office-based treatment, only about 25 to 60% of patients complete treatment. So we have a higher completion rate, which means we're more successful in completing treatment right now. And then, this is just really, we've done satisfaction surveys with patients and caregivers. And what we know is that essentially people are satisfied with telehealth services, that the rapport was just as good as in person. There wasn't really a big difference between using a computer, that the equipment was easy to use, which was a big worry. And we have, as far as caregivers, we actually had a caregiver in this study that was 86 years old who was very easily able to use the technology. So I think that this also dispels some of those myths. And then I think it was really important that 100% of our population said that they would recommend this to a family member or a friend. So there, again, satisfaction with it is really high. So, I mean, I'm not going to belabor all of this, but basically what we found is that our types of treatment that we do, the trauma-focused treatment, is absolutely feasible. It's something that people like, it's acceptable to them. And then not only that, is it's showing to be just as effective. And so looking at all those health disparities, transportation, time off work, missing school, payment for services, all of these things we can help reduce with using things like telehealth to get those services out there. And so to me, if you can do that with our very specialized trauma treatment, it obviously has utility across many, many domains. So I know that was a lot of information in a very short amount of time, but I did want to save some room for questions for people to ask a little bit about policy, telehealth procedures, our program, things like that.
Thanks so much, Meg. That was awesome. Does anybody have any questions for Meg?
I'm going to minimize so I can see people. So I know this is a nursing association. Is everyone primarily working in like institutions or private practices, or kind of a mix across the board?
Well, we're all pediatric focused, but some would be acute care in institutions, others primary care, outpatient, some school-based, and so on.
Gotcha.
I happen to work in the same school-based program that Meg does, and so I've seen firsthand the children that we've referred and the outcomes that they've achieved through this program. And I remember a few years ago when we first started, Meg and her coworker, Dr. Reagan Stewart, developed or adapted the TFCBT tools to use through telehealth. And they were the first team actually in the country to have done that. So she's being kind of modest when she is saying, I'm not going to belabor, but it was very impressive to see how they converted things like storybooks and so forth that they use in this type of therapy to be digital format so that they could engage and continue the therapy the way they would in person, but through distance. And so it's really been fascinating to me to see the program grow and expand and see the incredible outcomes that they're now demonstrating. Does anyone have any questions either about the program or anything related to mental health and health policy? We've got our telehealth mental health expert here.
I see one that
Meg,
just came in. Oh,
yep, there's one in the chat, Meg.
yes. So I see from Jennifer, how is provider satisfaction? So I think for our program, we found that provider satisfaction has been really powerful, but just from a personal anecdote, I will tell you that when I started doing telehealth, I was fresh out of grad school. And so I had about a year under my belt and was very founded, and all of my training had been done in person. And I did community-based approaches. So I was going out into the community in the homes and seeing people in non-traditional settings, but I felt very connected to being able to like get on the floor and like play with the kid in the moment and have these activities. And so I was on the program, but kind of like, we'll see how this works. I'm not sure if this is going to be the best fit, or like, maybe we'll see some benefit, but I don't know. I still think in person is better. And now 5 years, 5 years later, I actually love doing telehealth. I find it really rewarding because I think because most of the kids that I see are kids that without this type of program would be adults, but before they get services, they're going to be the adults that are having so much difficulty because they never got the services as a kid. And so it helps me. I think that helps with my satisfaction, is knowing that like these are the kids that get missed. And then, with our program, we started with nothing. So like Kelly was saying, we kind of started creating things from scratch, but now 5 years later, we have so many resources that we've created, and that, it's not any more difficult than in-person services to prep or be ready because we have that resource list together. I still like seeing kids in person, but I have many patients that I've never met in person. I've only met over a computer, and I still feel very connected to them and like I can do my job. The next question I see is, what is the most challenging in making the format change? So I would say, I think it goes along with is provider being comfortable. So surprisingly enough, I think a lot of my